400,000 cases per day, which went back down again. And now we're at this precarious plateau, which seems to be inching up day by day with the latest numbers of about 60,000 cases a day. I'm going to get back to this in a moment because, as you'll see, we are really in a race between a very, very effective vaccine, which I'll describe in a bit, and this difficulty of the possibility of yet again a fourth surge, which everyone is concerned about. Now, talking about some characteristics of the epidemiology, unfortunately, this particular infection is showing a great disparity among African Americans, Hispanics, as well as Native Americans, Alaskan Natives, and Pacific Islanders with regard to not only the relative proportion of cases, but the severe outcomes, which are as a result of the comorbidities that many minority populations have. Moving on quickly to the virology, I wrote this paper in the Journal of the American Medical Association over a year ago, and I chose as the title, Coronavirus Infections More Than Just the Common Cold. I wasn't trying to be facetious with the title, but I just wanted to point out to the readers of this viewpoint that we have had experience with coronaviruses for decades and decades, because as a matter of fact, as shown on this phylogenetic tree of the virus, all of the human viruses are shown in a red font. The yellow highlighted viruses are what we call the common cold coronaviruses, where these four viruses account for about 15 to 30% of all of the common colds that all of us experience repetitively year after year. But then in 2002, we had the first experience with a pandemic-like coronavirus. As many of you recall, the SARS coronavirus, which originated in the Guangdong province of China, and as a matter of fact, lasted for about a year with 8,000 infections and close to 800 deaths. It was able to contain itself because of good medical practices in the sense of good public health practices. And then in 2012, we had the MERS coronavirus, which is still somewhat smoldering. And then fast forward to the present time, when you have now the third pandemic coronavirus, the one we are currently experiencing. So let's move on quickly to the virology. This is a beta coronavirus. It's an RNA virus with 4 structural proteins, the most important of which is one we've heard a lot about with regard to the vaccines, and that is the spike protein. Actually, if you look at the picture on the lower right-hand part of the slide, the spike proteins stick out from the surface of the spherical virus, which gives it the impression of a crown, and hence the name coronavirus, which stands for crown. That particular spike binds to a receptor called the ACE2 receptor on the cells in your upper airway, your lungs, your GI tract, and your heart, which actually accounts for the multi-system disease associated with COVID-19. We are dealing today with a number of variants. What is a variant? A variant is a version of a viral strain that has been modified by any of a number of mutations. This can sometimes interfere in a way with the function by making it more transmissible or more deadly. The one we're focusing on very much right now is one referred to as B117, which originated in the United Kingdom, but is now the dominant lineage in the United States. The good news about this is that the currently using vaccines that each of us are hopefully getting covers this particular lineage very well. Whereas some of the others, for example, the South African isolate, diminishes somewhat the effect of the vaccines, which may require our getting a boost somewhat later on. Quickly going over to transmission. As we all know, this is transmitted through the respiratory route, both by droplets and aerosol. Although it is found on contaminated surfaces, the modality of transmission this manner is really probably minimal. However, we still need to pay attention to it. The virus is found in various body fluids, but again, the role of transmission is really dominated by the respiratory route. Again, of note and very unique for this infection is that at least 1/3 and up to 40% of the people who get infected have no symptoms at all. And importantly, about 50 to 60% of all the transmissions come from someone who has no symptoms. Either they will never develop symptoms or they are in the pre-symptomatic stage of infection. The fundamentals to prevent acquisition and transmission of the virus are what you hear about every day from myself and other health officials. The universal wearing of masks, the maintaining of physical distancing, the avoiding of crowds in congregate settings, doing things outdoors more preferably than indoors, and frequent washing of hands. There are multiple types of diagnostics. The one that's the most sensitive is the PCR molecular test, usually from a swab of the nasopharynx. It's highly sensitive and specific, but unless you're right near a good facility, it may take days to get an answer. The other one is an antigen test, which is used more for surveillance. It is not quite as sensitive as the PCR test, but it is very useful trying to screen large numbers of people to determine the penetrance of infection in the community. And then there's the antibody test to determine if someone has already been infected with the virus. The clinical course is interesting. Following infection, the initial presentation is very similar to what we call a flu-like illness, with fever, cough, fatigue, muscle aches, maybe some shortness of breath. There is a peculiarity of the presenting signs and symptoms, and that is this unusual and somewhat unique loss of smell and taste, which precedes the onset of the respiratory symptoms. Of those who do get symptoms, 80% or so are mild to moderate, where about 15% have serious or critical symptoms, leading to a case fatality rate of anywhere from a few percent to up to 20% in those requiring mechanical ventilation. The manifestations of severe disease are dominated by the acute respiratory distress syndrome or overwhelming pneumonias. But as we learn more and more about this infection, we see that it can be multi-system in its severity, with kidney injury, cardiac dysfunction, neurological disorders, and what's called a hyperinflammatory state, usually later on in the illness, where the inflammation is more damaging than the actual virus itself. Children can get a multi-system inflammatory syndrome, which can be very severe. It is rare, but when it does occur, it's very severe. It resembles a syndrome called Kawasaki syndrome. Now, the people who are at increased risk for severe COVID-19 are older adults and people of any age who have certain underlying medical conditions, such as obesity, hypertension, kidney disease, etc. The sequela in adults at 6 months after COVID-19 infection is often referred to as long COVID, but it really is more appropriately called a post-acute COVID sequela syndrome. About a third of these people who have been studying at various places have the persistence for as long as 9 months, usually characterized by fatigue, muscle ache, temperature dysregulation, sleep disorders, and something that's referred to as brain fog, which means they have difficulty concentrating or focusing. Treatments have been, in some respects, very rewarding, and in others still very challenging. One can think of therapeutics as broken down into those for early to moderate disease or moderate to advanced disease. Several of these have been proven or disproven by randomized placebo-controlled trials, such as remdesivir, which is a direct-acting agent that has received FDA approval. Several monoclonal antibodies, such as those from Lilly and Regeneron, have gotten emergency use authorization, as has convalescent plasma. These are generally much better utilized when given early in the course of infection. As I mentioned a moment ago, therapeutics for advanced disease are probably the biggest success story, with dexamethasone, a common corticosteroid, which has been shown to diminish the 28-day mortality in people who require mechanical ventilation and/or high-flow oxygen supplementation. The big challenge for therapeutics, and what we really need more than anything else, and we're making a major investment in developing this, are direct-acting, orally administered antivirals similar to those that we successfully developed with truly spectacular success in HIV, as well as in hepatitis C. We have a treatment guidelines panel established by the NIH, which is a living document where all new clinical data are immediately registered so that clinicians throughout the world can have access to the latest recommendations for treatment. As I mentioned, the real challenge is to identify vulnerable targets in the replication cycle and to design drugs to inhibit these vulnerable targets, similar to what we did with HIV and hepatitis C. And finally, vaccines, the true success story in this historic pandemic. Science has called the accomplishments in the work of the vaccines as the scientific breakthrough of the year of 2020. The federal government has invested billions and billions of dollars in supporting the development of and/or the clinical testing of 6 products representing 3 platforms and 6 companies, 3 of which have already received emergency use authorization. The mRNA of Moderna and BioNTech Pfizer, the human adeno of J&J, and other companies will soon be applying for an emergency use authorization. One of the things that's very noteworthy is that vaccines usually take literally years to develop. But because of the extraordinary advances in the science of vaccine platform technology, vaccines have now been produced in less than a year. One of the examples, one that was developed with a big input from the NIH Vaccine Research Center, was the Moderna mRNA vaccine. When the sequence of the virus became available on January 10th, 65 days later, a phase 1 trial was begun, and 11 months later, a 94% effective vaccine was put in the arms of people in December of 2020. These are what's called the Kaplan-Meier plots, where you look at the cumulative incidence of the occurrence of COVID-19 from two companies, Pfizer, BioNTech, and Moderna, and look at the striking difference in cases in the placebo in red versus the vaccine in blue. J&J is also now has a highly efficacious vaccine that was tested in multiple countries, including South Africa, in which it protected against severe disease in the South African lineage. When you look in the real-time efficacy of these particular vaccines, they continue as effective against severe disease as well as any disease. Bottom line is, these are extraordinarily good vaccines. And as I mentioned early on, we are now in a race between the vaccine and making sure we don't have another peak or surge. Of note, these vaccines also are highly effective against adolescents, with a recent trial showing 100% efficacy in children 12 to 15 years of age. So finally, let me close with the concept of efficacy versus effectiveness. If you look at the vaccine doses in blue, look what's happening with the cases in Israel. It's having a profound effect in controlling the outbreak. The same holds true in medical centers, such as here in Dallas, Texas, in the University of Texas Southwestern Medical Center, where look at the blue bar on the left of unvaccinated people, the middle bar partially vaccinated, and the far right bar, the vaccinated people, fully vaccinated, with an incidence of 0.05%. Another study looking again at frontline workers, a very, very low incidence of infection. Now we have to deal with vaccine hesitancy, which can be a real problem. But thankfully, what we're seeing as more and more striking results are given, we actually see more and more people. There was a concern about a number of things, potential side effects, things that are unrealistic as well as things that are realistic concerns. What we're doing is getting prominent people like the president and the vice president shown here getting vaccinated, or even those of us at the NIH, with me in the middle, NIH Director Francis Collins on the left, and former HHS Secretary Alex Azar on the right. What the goal is to reach out to communities. This is a slide showing a Zoom meeting I had with Jonathan Nez, the president of the Navajo Nation. I got involved very heavily with Black churches. Here's one of them in the Boston area. One of our scientists, Kismekia Corbett, shown here with Reverend Jexie Jackson getting vaccinated. The important thing is that we have developed what's called a COVID-19 community core, in which we are going to be getting trusted messengers in society, entertainers, sports figures, clergy, other individuals who can utilize the information from the CDC to get people to get vaccinated, because to be absolutely certain, our way out of this is going to be by proper implementation of vaccines. So I'll stop there, and I'll be happy to answer questions.
Thank you so much, Dr. Fauci. You have given us quite a bit to unpack there. But I want to start with the news that's actually happening today. Some states are seeing surges in COVID cases right now. What do you think most attributed to these surges, and what can be done to bring the cases back under control?
Well, the answer to your second question I've given you, but I'll repeat it because it's important. And that is to get as many people vaccinated as quickly as you can, but also to not pull back on the mitigation methods of public health recommendations, because several of the states are pulling back on mask mandates. They're pulling back on restrictions on capacity for restaurants and bars. It is premature to declare a victory. We've got to continue and hang in there a bit longer by continuing with the public health measures. The other thing that's contributing to it is this issue of the variants that have now become dominant, particularly the 117, the variant from the UK. All of these can be handled if we just stick for a bit longer with the full court press on the mitigation. We'll be able to pull back for sure as we get more and more people vaccinated. So we don't want to be too premature in saying, okay, we could go ahead and just let it fly, no more masks, don't worry about congregate settings. That would be a mistake. That would be a mistake.
You talked about the COVID community core that is being organized and the efforts to reach out to the public. Can you talk specifically about your message to young people? Because we found, there have been reports anyway, that young people especially are contributing to the rise in the number of COVID cases that we're seeing.
Yeah, we wanted to impress on the young people that even though it is less likely that they will have a severe outcome, we're seeing more and more young people get into serious trouble, namely severe disease, requiring hospitalization, and occasionally even tragic deaths in quite young people. So there are a couple of reasons why younger people should get vaccinated. The one of them, as well as should not just feel that they're invulnerable and go out not wearing masks and going to the kind of congregate settings that you sometimes see, where people crowded at bars or wherever, is that one, you want to protect yourself. But importantly, you have a societal responsibility, because even if you get infected and don't get seriously ill, you are still propagating this outbreak, because by getting infected, even if you get no symptoms, it is very conceivable, if not likely, that you'll infect someone else, who will then infect someone else, who then may infect someone's mother who's on chemotherapy for breast cancer, or an elderly grandparent who, because of their age, is more susceptible to severe outcomes. So you got to think not only to protect yourself, you've got to think of the responsibility you have to society, which may even include your own family members and friends.
You mentioned in your presentation that we're in a race against the vaccine and the virus. Are we actually in a fourth wave right now? Is that what we're experiencing?
No, we're not. We've plateaued down and we're just essentially tempting another wave. Another wave is when it goes back up. It's gone down and flat. It's inching up from 30,000 to 40,000 to 60,000 a day. If it really takes a turn and starts surging up, that's what we would consider. We're really on the brink of a surge. That's why I mean it's really a critical time right now, because we could just as easily swing up into a surge. That would be a setback for public health, but that would be a psychological setback too, because people are really have what we call COVID-19 fatigue. And we just don't want to have to go back to really shutting things down. That would be terrible.
So this morning I heard, and as I mentioned to you, I work at the Associated Press, a couple of reports that the CDC is giving advice to the airlines now about cleaning. I personally was very happy that they were taking so many precautions and were doing the massive cleaning on the airplanes, because they can be really gross when you get on the airplane. Are you sending mixed signals to the airlines and to folks who are traveling now that you've told them that they can step back and not do the amount of cleaning that they were doing before?
Well, I think we want to make sure we got to be careful about that. There are recommendations for cleaning, and then there's recommendations for disinfectant when you have someone in a home, for example. What we're saying is that without a doubt, respiratory transmission is the major modality of therapy, not touching something. That doesn't mean you don't clean it. You need to clean intermittently. You need to make sure that, particularly if it's grossly soiled, you want to do it. But even if it isn't, you've got to clean occasionally. But you don't want people to be obsessed with cleaning and scrubbing everything, putting a lot of effort in. It is possible that it's spread that way, but the overwhelming modality of spread is through person to person, as opposed to touching something.
So on an airplane, you're in close quarters with people. They're not doing the seat between a person, an empty seat between a person anymore. And I mean, you can catch a cold on a plane. So what do you do when you're on an airplane? I mean, beyond the mask wearing, is there any other kind of precaution you can take when you're on the airplane?
Well, no, you wear a mask, number one. And the airlines have a pretty good HEPA filter system where they filter the air. So it would help, but you know, when you see a picture of people sitting like this, that gets you nervous. One of the reasons why the CDC makes it very clear that right now, with this level of infection in the community, we should probably try to avoid travel if we possibly can, and limit travel to what we would call essential travel.
Up until when?
You know, up until we get a substantial proportion, the majority at least, of people vaccinated, and the level of infection goes very, very low. Everything is at the risk of the level of community infection. When community infection is high, and that is the 60,000 new cases per day that I mentioned just a moment ago, everything you do is going to be at risk if you don't have the kind of precautions that I'm talking about. That's the reason why you don't want to have theaters that have closed systems. You have limited seating at ball games. You have limited attendance at different events. When the level of infection goes way, way down, the risk is going to be less. You're going to start seeing greater capacities at ball games, restaurants having greater capacities, safer to fly. All those things relate to the level of infection. You bring the level of infection down, the risk goes down. The level of infection that's high in community, the risk across the board goes up.
I almost hate to kind of hammer on this, but I mean, people are planning trips for summer vacation. which require
Right.
flight or train or so if the levels stay the way they are right now, will it be safe to travel on the airplane?
It's all relative. It's all relative, the safety. I mean, right now, flying is, because of the HEPA filter, because of the use of masks at the level of infection in community, it is a risk to fly, but it's a small risk. The more infection you get in the community, the greater the risk.
Okay.
So if we get more and more people vaccinated, by the time we get to the summer, the risk of flying will be even less than it is now. So I would hope, and I believe this is going to happen, that as we get the 3 to 4 million people vaccinated every day, so far 62 million people have been fully vaccinated. Over 100 million have received at least partial vaccination. You add to that 3 to 4 million people a day getting vaccinated. We're at April the 6th now. By May the 6th, 3 million times 31, you're almost at 100 million people who have now been vaccinated. I think that by the time we get to people wanting to travel in the summer, we will be much better off than we are today.
A lot of people pay very close attention to what you do, Dr. Fauci, and the choices you make to keep yourself safe. And I am very proud to say that I am a member of the House of Moderna, and I will be getting my second shot at the end of the month. They'll say something like, you know, I'll get on an airplane if Dr. Fauci gets on an airplane. It begs the question, when do you think you yourself, when are you going to fly? When are you going to feel comfortable to fly on an airplane?
Well, I'm not a good example. Let me tell you why.
Okay.
Because the nature of my job doesn't get me on a plane. I'm here. I'm locked into Washington right now for what we have to do here. So I would feel comfortable flying. You know, I'm vaccinated right now. If I had to do something that was essential flying, I likely would feel comfortable now being vaccinated to fly. I would. But since I don't have to, I'm not a good example. I can tell you, if I have to go someplace this summer, like with the family, I would not hesitate to do that. If in fact we continue to come down on the infections and more people get vaccinated.
I think you just calmed the nerves of half of America just now.
Well, good. I'm glad I was able to do that.
Going back to some things that are actually breaking today, the Detroit Free Press has reported today that there were some significant occurrences with folks that are in nursing homes who've been fully vaccinated, with 3 of those folks who were fully vaccinated dying. Something that, you know, I've heard and we've been getting questions about, people think that once they get the vaccine that they're good to go and that they will never catch the virus. Can you talk a little bit about the chances of you catching COVID even after you've been fully vaccinated? And in the case of these 3 senior citizens in Detroit who passed away, unfortunately, after they were fully vaccinated, is it more likely to be a problem for senior citizens or for the members of the elderly?
You know, I think you just hit the nail on the head right there when you talking about it isn't unidimensional across all ages. If you look at the efficacy of vaccines, the efficacy against any kind of symptoms for the Moderna and the Pfizer are, 94, 95%. The efficacy against severe disease across all ages is about 80+%. The efficacy against death is very, very good. But as you get older and have underlying conditions, it is likely that the protection you get is not necessarily as good as the protection that a 30-year-old otherwise healthy person. So although those deaths are tragic, you don't want to see anyone succumb to this disease, be they in a nursing home or perfectly well outside. It is not totally surprising that you're going to see some cases of people who've been vaccinated who the infection broke through, particularly if it's in a variant that isn't as well covered by the vaccine. For example, the 117, which is the UK variant, seems to be pretty well protected against by the vaccine. But there are other variants, such as the South African variant, which is not as well protected. Doesn't lose all the protection, but the protection goes down somewhat. It is likely that the New York variant and the variant from Brazil loses some of its potency, the vaccine potency when you get infected with that. So there are a lot of complicating issues. So even though we should not start worrying that the vaccines aren't protecting us, nothing is 100%. That's the thing you've got to realize. Nothing really is 100%. So you're going to start seeing breakthrough infections. You shouldn't get discouraged by it, but you shouldn't be surprised by it either.
So speaking of how long a vaccine lasts, the protection of a vaccine, we heard that for Pfizer, it's 6 months after. It's really good, still really good. How are you following up, and what are you looking at in terms of the possible need for a booster shot? Because, I think of this like the flu, right? I mean, no one has to get a booster shot when you get the flu. You get a flu shot and, there's no booster, but we're hearing about the need for possible booster shots later on. Yeah, go ahead, hit me.
Careful. I'm going to hit you.
Hit me.
You get a flu shot every year.
Right.
That essentially is a booster in some respects.
So will we be getting a COVID vaccine every year like we get the flu?
It's possible. It is possible. See, you get a flu shot every year because the virus changes a bit. It drifts. So just to be precisely correct, it will save me hundreds of emails if we get precisely correct. So let's zing on the correct thing here. When you're talking about durability, that means if you get an immune response against a specific virus, and over time, if nothing else changes, it is conceivable that the level of protection goes down and down and down until you get a certain level that isn't quite protective. You need a boost to that same virus. That's the classic boost. So what you're saying is, we know it lasts for 6 months because we've only looked for 6 months. It could be 8 months, a year, 2 years, 3 years, we don't know. So what we're going to do is we're going to follow people to measure the parameters of immunity to see how long it lasts. If it lasts way out, we may not have to boost it. If it starts coming down, we may need to boost it. Now, to be precise, there's also the issue if a variant comes in, which this particular vaccine doesn't cover as well. Same like flu. You get one kind of flu this year, you got to get vaccinated next year, not because the immunity didn't last, is because the virus changed. So it is conceivable that in addition to the duration of the immunity, if you're dealing with variants of the SARS-CoV-2 that actually change, that might be another reason why you got to come in with another shot, either a shot against the original one or a shot against the new variant. Bottom line is, you pay attention to what's going around, you measure the level of immunity, and when you need to boost it up, you boost it up.
So you just gave me like a whole nother set of questions. You know that, right?
Of course.
Whole nother set of questions. And some of these questions may seem rather simple, but we're taking them from the listeners? You know, ordinary people have questions that, you know, might not be
And
asked in science, okay?
but they're important questions
Yes, they
for
are.
anybody.
So,
Right.
if you get your first shot of Pfizer or Moderna, does it matter if you don't get the second shot with the same vaccine? Or is it even possible for you to get like the first shot of Pfizer and then go back and get a second shot of Moderna, vice versa?
Okay. That has not been studied to give a definitive answer.
Okay.
However, given that they're both mRNA virus from mRNA vaccines, since they're both mRNA vaccines, conceptually, it just makes sense that it shouldn't be much different by getting a Moderna followed by a Pfizer, even though the studies have shown that you should get Moderna followed by Moderna, Pfizer followed by Pfizer. We're now looking at to see if there's any difference if you do one followed by the other. Why are we doing those studies? We're doing those studies because human nature tells us that people will get one and either forget, lose their card,
Right.
not know which one they got, and go and say, I know I got the mRNA, but I don't know which one. That's why we're doing a study to see if there's any difference. I would predict that there's not going to be any difference between the same two or one followed by the other.
I doubt they're going to say, I know I got the mRNA, because they're more likely to say, I got the FAUCI ouchie, or something like that. So,
Right.
and speaking of which, can we talk a little bit about what is going on with AstraZeneca? All of the stories about clots and everything. What's going on with that vaccine?
Okay, what I would recommend, you're absolutely, you are hinting that there's a degree of confusion here.
Indeed.
And your hint is on the money, because there is. The easiest way to get this settled is that AZ will be and are in the process of submitting their data to the United States Food and Drug Administration to apply for an emergency use authorization. The FDA, our USA FDA, meticulously goes over all of the data in a way that no other organization does. When they come out with their decision as to an EUA or not, then I think many of the questions that people are asking about the possibility of clotting, adverse events, how effective it is or isn't, those questions are going to be answered. But you're right, up to now, there's been a little bit of a confusion about that.
What can you tell us about the Novavax vaccine? You had that up in your presentation just a little bit for like 10 seconds. What can you tell us about that vaccine, and how does it measure up to the other vaccines in terms of efficacy?
You know, the preliminary data that we saw from the UK and South Africa actually looked quite good. It was approximately 90% efficacy against any clinical disease. The efficacy against severe disease, there weren't enough people in that particular component of the trial. We are going to be doing, as we've said, we're going to be taking a look at those data when they come, for us to look at in the United States, likely by the end of April, the beginning of May, and we'll get a good feel. But what I saw, I was quite encouraged by.
What about the vaccine in a pill form? Because nobody likes to get a shot, but we're hearing about the development of pills. What do you think about that?
I think orally administered vaccines certainly are promising, particularly since they tend to immunize the oral mucosa and the mucosa as opposed to, systemically in the muscle. That some orally administered vaccines could have an even greater effect than the intramuscular administered, but we don't know that yet. They're being studied. So there is not right now nor will be there in the immediate future an orally administered coronavirus vaccine, even though there are laboratories that are working on it.
Okay. A question from Marilyn Marchione at the Associated Press. What can we do now to better prepare for the next pandemic? And what do you see as the biggest gap or the need in terms of treatment for COVID-19?
Yeah, let me answer the second question first, because that was one of your questions.
Right.
And I had 2 slides on them. So I could tell Marilyn if she was watching my lecture, instead of looking at something else, she would have gotten it. Just kidding. Marilyn's a friend. Actually, the real gap that I'd like to see filled is an orally administered direct antiviral agent that can prevent people who present with symptoms from progressing with symptoms and getting to the hospital. So that slide that I said, targeted antiviral, looking at the vulnerable points in the replication cycle of the virus, so we could have an orally administered medication very similar to what we have for HIV and for hepatitis C. That was the second question. What was the first question?
Well, actually, I'm going to change the first question. So would you say that that is your top priority for improving treatment?
Yeah, I do. I mean, myself as a virologist, immunologist, I believe that if you look at the spectacular successes with anti-HIV medications and hepatitis C, to get a good, potent, orally administered drug that as soon as someone presents with symptoms that clearly looks like COVID-19, give them 7 to 10 days of a drug and they'll be done without progressing onto the serious consequences.
So are we looking are you looking at something, are you talking a little bit of something like when you you have to take like prednisone or something like that when, you know, the doctor gives you...
Prednisone is different, see, because prednisone, again, I know I went a little fast and I apologize, but you can look at therapies of 2 types, those for early to moderate disease and those for severe disease. Early disease is directed predominantly against the virus itself to prevent the virus from triggering these aberrant inflammatory and immunological responses that later in the course of disease are likely the cause of severe disease and death. Dexamethasone, or steroids, they are used to block inflammation and are quite good when you have advanced disease, either requiring a ventilator or high flow oxygen. You want to dampen the inflammatory and the immune response because it's overactive. You don't want to give that drug early because early you want the immune system to fight the virus. So you want to give the anti-inflammatories late in the course of disease and direct antivirals early in the course of disease.
Okay, we're getting so short on time. I could talk to you for 2 hours. As a public health measure, do you expect vaccine passports to be required around the world? I know I'm going to Aruba this year, and they're already requiring that I get their insurance when I come into the country, which I'm going to do. But I mean, wouldn't it be great if I just had a vaccine passport? Is that good?
So you're going to Aruba. That's the reason why you're asking about flying.
Absolutely. Huh? It's all about me.
You know, when you say required, that's an interesting word. I can tell you that there's always talk about verification
right.
Of vaccination. That almost certainly, to some extent, is going to be done at the local level, even in our own country, but even more likely when you want to go someplace in a foreign country, similar to like a yellow fever vaccine card that you get and you can't get into Cote d'Ivoire or Liberia or places like that unless you have that card. It's not going to be federally mandated. I'll guarantee you. I would be very surprised if the federal government, our government, ever made a decision that you have to have a vaccine card to go any place. But what you might see is individual entities like theaters or ballparks or other places saying, you know, I'm sorry, I want to see some validation or I won't let you in. It's perfectly within their right to do that if they want to. I mean, I'm not sure that's going to happen, but the one question we always get asked is the federal government going to make those impositions? And that I almost can guarantee you is not going to be the case.
I need to ask one more question before we get to our close, and I don't want to leave off parents who are concerned about their kids getting vaccinated because that's an issue. How soon will we know if vaccines are safe and effective for children that are 1 to 12 years old? And I know that there are some tests that are going on, and we've seen reports of it. Can you talk a little bit about the trials that are going on in children?
Yeah, well, there's already a trial in adolescents from 12 to 15 shown to be 100% effective. There were 18 cases in the placebo group and none in the vaccine group. A couple of companies, including Pfizer and Moderna and others, are doing what's called age de-escalation studies. So you look at, you don't want to jump and get all the kids together. You want to gradually work your way down in age because the younger the kids are, the more vulnerable they are. So for example, an age de-escalation study would look at children 12 to 9, then 9 to 6, then 6 to 2, and then 6 months to 2 years. By the time we get them all done, we think it'll be ready. We think it'll be ready to give it to children no later than the end of this year and the beginning of the first quarter of 2022.
Okay. Well, before I ask the final question, let me take a moment to thank the organizers of today's event, headliners, co-team leaders Donna Linewan and Lori Russo, today's headliner event coordinator Bill Pierce, Club Communications Director Lindsay Underwood, and Club Executive Director Bill McCarron. I'd also like to tell you about some upcoming Press Club headliners. On Monday, April 12th, we'll hear from Washington Post reporter John Woodrow Cox, author of Children Under Fire, An American Crisis, on the impact of gun violence on children in America. And on Tuesday, April 13th, we'll hear from award-winning CBS journalist Marvin Kalb, who will share the second volume of his personal memoir, Assignment Russia, Becoming a Foreign Correspondent in the Crucible of the Cold War. And we hope you will join us. So we've had a very serious hour, Dr. Fauci. Would you agree?
I agree. It's a very serious issue we're dealing with.
It is indeed. But people love you and people hate you. So talk a little bit about how it was working in the Trump administration. That's right. Yeah, people love you, people hate you. How was it when you were there? I mean, when you were on the CNN interview, you know, you were very forthcoming, but talk to us about the pressure you were under.
You know, to be honest with you, I don't like to do that. The reason is, let me explain to you why.
Okay.
The reason is that if you keep, you know, rehashing all of that, you know, if you keep rehashing it, it creates a degree of hostility with the very, very, very many people who still are loyal to Trump.
Okay.
And, you know, if you say anything that's even slightly negative, you wind up distracting from what we all need to do right now. So rather than look at how difficult it was or was not back then, I really want to use all of my energy to look ahead about how we can end this under what we're going on right now. So I'm sorry for pulling away from what,
I had to ask you that. You know, if I didn't ask you that, people would take me to task, right?
Yeah.
So
there are so many more important things to do than go back and rehash that.
That is true. You've received a lot of accolades during your career for your achievements in public health and virology, but it took until 2020 for you to merit your own bobblehead. How do you feel about that?
You know, it gets back to what you just said a little bit ago when you were asking me the question. Yeah, it took until 2020 to merit my own bobblehead, but it took until 2020 to require federal agent protection for me for people who threaten my life.
Amen.
So, it's a strange world.
It is
It's
indeed.
a strange world.
What do you
Yeah.
do to decompress, Dr. Fauci?
Well, I used to run. Now I walk really fast. So I exercise every day. That's the one thing I do. I do it with my wife generally in the evening and on the weekends during the day. But that's the one thing that I still love to do to decompress.
Well, we really appreciate you taking care of yourself and taking care of all of us throughout the country. We appreciate your guidance and we appreciate your time today here at the National Press Club. You know, we usually have you in person and we usually have some cookies ready for you and have you at the head table, but this was fantastic. Thank you so very much for your time today, Dr. Fauci.
I appreciate it. Thank you for having me. It's always good to be with you. Look forward to doing it in person sometime soon.
Absolutely. Thank you.
Take care.